Domnul secretar, noi începem, da?
Da.
Ok, bună ziua, onorată asistență. Vă felicit pe toți cu începerea Congresului aniversar al Universității de Stat de Medicină și Farmacie Nicolae Testemițanu, aniversar la 75 de ani. Astăzi, în echipa de moderatori, vreau să-l salut pe domnul profesor Adrian Hotinianu, doctor habilitat în medicină, domnul conferențiar universitar Dumitru Casian, doctor habilitat în medicină, și cei care sunt astăzi vorbitorii. Lecția ne citește domnul profesor Frank Lee Bowling, care a absolvit, vreau să-i fac o mică prezentare, a absolvit cu succes doctoratul clinic în podiatrie, iar ulterior a obținut o diplomă de master în teoria chirurgiei podiatrice. Ulterior și-a continuat cariera academică și a absolvit un doctorat în filozofie la Facultatea de Medicină. Domnia sa este autor și coautor a unor serii de reviste medicale, inclusiv 12 capitole de carte și 2 cărți de farmacologie: Managementul bolilor, Neuropatia diabetică, Biomecanica și Piciorul Charcot. Profesorul i-a fost acordat premiul Top Clinical Abstract Advance în cadrul simpozionului de îngrijire a avansării rănilor, National Institute for Health and Research Clinical Leadership Awards, precum și Trust Chairman Research Prize Scholarship. Totodată dumnealui este membru a Societății Regale de Medicină, membru al Consiliului Profesiilor din domeniul sănătății, membru a Colegiului de Podiatrie din Londra, Marea Britanie. Din 2020 s-a conferit eminență de funcție de profesor, afiliat Centrului Academiei de Științe ale Sănătății, o colaborare între Institutul Național pentru Sănătate și Cercetare, care vizează subiecte legate de cancer, maladiile cardiovasculare, inflamație și regenerare, endocrinologie, sănătate mentală, sănătate populațională, sănătatea mamei și a copilului. Pe parcursul anilor, profesorul Frank Lee Bowling a efectuat multiple vizite în cadrul Universității de Stat de Medicină și Farmacie Nicolae Testemițanu, oferindu-i suport complet, sfaturile și încrederea în dezvoltarea continuă a cadrelor noastre didactice. Fapt pentru care, la data de 9 mai 2018, i s-a conferit titlul onorific de Visiting Professor al Universității de Stat de Medicină și Farmacie Nicolae Testemițanu. Deoarece domnul profesor vorbește limba engleză, astăzi, în cadrul ședinței noastre pe care o avem, lecții date, limba de comunicare va fi atât limba română cât și limba engleză pentru vorbitorii de limba engleză. De aceea rog domnul profesor Adrian Hotinianu să prezinte și o anumită informație în limba engleză. Domnul profesor, vă rog.
Dear colleagues, I want to introduce a little bit about a biography of Professor Frank Lee Bowling, a friend of our university, and the topic of this presentation is new treatment modalities in vascular intervention, innovation and intervention, a step in the right direction. Professor, Doctor of Philosophy, School of Medical Science, University of Fellow of the Faculty of Pediatric Surgery, Podiatric Surgeon, College of Podiatrists, Manchester, UK. Short biography. Professor Frank Lee Bowling successfully graduated with a clinical doctorate in podiatry, and later he undertook a Master of Science degree in the theory of podiatric surgery. He later carried on his academic career pathway and completed a philosophy doctorate in the Faculty of Medicine. Since graduation, he has authored and co-authored a range of medical journals, including 12 book chapters and 2 books of pharmacology, disease of management, diabetic neuropathy, biochemics, pathomechanics, and charcoal food. More recently, he was awarded Top Clinical Abstract Award at the Symposium of Advanced Wound Care, National Institute for Health and Research Clinical Leadership Award, renowned Medical Innovation Award, and also the Trust Chairman's Research Prize Scholarship. Since 2020, he has been given an extremely eminent position as a professor that is linked to the Academic Health Science Center. This is collaboration between the National Institute for Health and Research that covers the topics for cancer, cardiovascular inflammation and repair, endocrinology, mental health, population health and implementation, and women and children. Over the years, Professor Frank Lee Bowling has made multiple visits to our university, offering his full support, advice, and confidence in the continuous development of our teachers, which is why on May 2 years ago he was awarded the honorary title of Visiting Professor of Nicolae Testemițanu University.
Ok, fiind cele spuse, tema este una destul de interesantă și eu cred că este necesar de a procede la desfășurarea lecției respective. Professor.
So, Professor Bowling, so you can present your presentation. So,
okay, just bear with us.
Yes, wonderful. We can hear very well.
Bună ziua!
Bună ziua!
Mulțumesc frumos! Okay, so my name is Professor Frank Lee Bowling. I am based at the University of Manchester and the Manchester Royal Infirmary. I am Professor of Surgery and Translational and Experimental Medicine with the National Institute for Health and Research in the United Kingdom and the National Institute for Health in the USA. My presentation today will focus on collaboration between different European universities. The main emphasis will be on how we can collaborate as two institutions, i.e. Nicolae Testemițanu and the University of Manchester, in conjunction with University of Oxford and Cambridge, to where I currently reside. I would like to thank, firstly, Professor Stanislav Groper, a friend and colleague of mine who works in research, as do I. Thank you, Professor Groper. It is extremely eminent to present for you today at the 75th Congress at the State University of Medicine and Pharmacy. As you can see from my first slide, we have what we call ASC, AHSC, which is the Academic Health Science Centre. This is based throughout Europe and is predominantly sponsored by the World Health Organization. What this does, it brings together big research-intense universities to work in collaboration with cross-fertilization of both academic and clinical skills. This is in conjunction with academic medicine in the US of A, where I also reside as a visiting professor. So I'm going to move to my next slide, on my first slide, and this is the collaboration we currently have within the United Kingdom. What we know from past experience is for research projects to take place, it needs to be done through multiple universities. One university alone cannot offer what we need from the clinical outcome. So what we try to do is bring different institutions together to answer any unmet needs from a clinical context, which is where both Dr. Kakani, Senior Lecturer and Consultant Radiologist, Interventional Radiographer here at the University of Manchester, will join in the next 5 minutes and explain how this collaboration will work. The current collaboration, in conjunction with Nicolae Testemițanu, is currently what's ongoing, as we currently have grants with, or are looking for grants with Professor Grover, which is where we need to be in the future. The Academic Health Science Centre has a unique breadth and depth in its research capabilities, and it's keen to work, as previously mentioned, collaboratively with business and other organisations for patient benefit and the wider society. We actively encourage academics, along with clinicians, along with scientists, to come up with research ideas and research proposals. This, in the 21st century, is the only way we can offer multi-centre European collaborative research. As previously mentioned, centres that stand in isolation very rarely perform very well on research grants. It must be about research collaboration. What I'm currently working on here in Manchester, and we have in part, is working with Professor Grover and the University of Manchester and Nicolae Testemițanu University, within collaboration, applying for grant applications across the European funding panels. As previously mentioned, we work with scientists, industrial partners to promote and facilitate both clinical and preclinical collaboration. Our areas of research and research excellence pretty much span all areas of medicine, both clinical and experimental. Through this partnership with Nicolae Testemițanu University, along with the University of Manchester, in collaboration, this is what we're looking for within the next decade. What I envisage is multi-centre grants with the University of Manchester and Nicolae Testemițanu University, working in collaboration, all for the benefit of the patient. I am currently working with the NIH in the US, the NIHR in the UK, and the European Public Health Alliance. Not to forget the European Institute for Innovation through Health Data. By working collaboratively with the World Health Organization, to which I currently reside on the panel for all of the above mentioned, this is how we can move research forward between our two respective universities. I am very proud and honoured, not to say the least, to have a professorship at Nicolae Testemițanu University, to which I've held for the last 2 years. This collaboration with research is what will move us forward within the 21st century. My colleague, Dr. Kikane, will move on to say how we can move this research forward from a clinical context, and how I can move this research forward from a funding aspect, i.e. from the academic side. What we do know from successful grant applications, everything must everything must be in collaboration. Without collaboration, simply it does not work. So as previously mentioned, my colleague Dr. Kikane, who is a senior lecturer here at the University of Manchester and a consultant vascular interventional radiologist at our respective health centre, will move on to talk about intervention and innovation for the future. What I would like to put the emphasis on before this presentation starts is this is about collaboration between our universities. and this is about what we can offer you clinically and both academically, and what you can offer us respectively, again, both clinically and academically. It's a huge pleasure to work with Professor Groper, and it is always a pleasure to attend Moldova, but unfortunately, due to this COVID era, this is not possible. I do look forward to seeing you all in the future, as I have some big ideas for our respective institutions with regards to funding bodies. For the next set of slides that you will see, I would like to bear in mind when you're looking at these slides, this is what we can offer you and what you can offer us. The fact that we do not have the academic context, because we certainly do, and that is in the way of our scientists in our respective universities. I will now pass over to Dr. Kikani, and once Dr. Kikani has finished his presentation, I will come in to close our section of this presentation. Mulțumesc frumos.
Thank you, Professor. Hello, Dr. Kakane.
Hello, good evening, I guess. It's there in Moldova, and it's afternoon here in Manchester. Good evening to all of you. Do you want me to start the presentation, or do you have anything to say prior to me starting?
Yeah, I think it will be after, so we can see the presentation after. We have some, I think, discussion about that.
Fantastic. Thank you very much. I'll try and go slowly, and there are a number of slides here, so for whatever reason you're unable to see the slides or unable to view the screen in any way or form, please let me know, please interrupt me. Otherwise, what we will do is we will take all the questions towards the end of the presentation.
That's wonderful.
Thank you. I'd like to begin by thanking Professor Groper and Professor Bowling here for inviting me to give you this lecture. It is an honor to be part of your 75th celebration of your State University of Medicine and Pharmacy. Last year, around this time, I was visiting Moldova, and I had the great opportunity to tour your university campus, and it is truly remarkable and wonderful to see all the great efforts that you all are putting forward. It is very impressive indeed. We were so impressed that when I came back from my visit to Moldova, I went up to Professor Bowling's office and I gave him an immediate feedback, telling him how excited I was to be able to contribute to intervention and innovation in Moldova and to work with all the wonderful people there are. So, as Frank mentioned already, I'm a consultant vascular interventional radiologist here at Manchester Foundation Trust. I have trained in vascular surgery in the University of Cambridge and then moved on to radiology in Plymouth, the United Kingdom. From there I worked in Canada, in University of Western Ontario for 9 years prior to me coming back to Manchester here to head the unit in interventional radiology and complex vascular procedures here in Manchester. I have no disclosures to say with regards to this presentation. I'd like to talk about what we all understand about interventional radiology or intervention as such, whether you're a cardiologist, whether you're a surgeon, whether you're a hepatologist, or whoever, whatever you're doing. Intervention is about a manipulated procedure controlled and followed under fluoroscopic guidance that may be predominantly therapeutic or occasionally diagnostic. We have moved away from the diagnostic culture to more of a therapeutic culture now. As you all know, father of intervention was Charles Dotter. In 1968, he accidentally discovered interventional radiology by cannulating a blocked artery whilst he was doing a diagnostic angiogram. Therein was interventional radiology, or intervention as such, was born much before cardiology was doing it, or much before vascular surgery was doing it, or vascular interventional people were doing it. And he truly is regarded as the father of intervention. Following him closely, we've had many people like Dr. and Judkins and Hamas here who have been instrumental in giving us the technology and the catheters and the innovation that is required to use in our field, because intervention truly is a modern, innovative specialty which moves at light years ahead of other specialties, primarily because it is surrounded by technology, it is surrounded by innovation. And I hope that during this lecture I will be able to convince you all that that is the case. We are very lucky that God, our Creator, has made us in such a way that He has given us a highway of systems in our body where we can reach from anywhere to anywhere. We can start at point A and point B, and just like you would navigate a complex road structures like you see on the left-hand side of your screen, we use GPS, or we use modern version of GPS in the form of X-rays to be able to navigate through the human body. And we use our guide wires and catheters of different sizes and shapes to be able to deliver this therapy, whether it is to place a stent, or whether it's to reconstruct, or whether it is to treat, or whether it is to address a bleeding point at some point. So interventional radiology, or intervention, has woken up in this century clearly, and it affects a number of areas. It affects the neurovascular, it affects the cardiothoracic, it affects vascular, hepatobiliary, nephrology, gastroenterology, peripheral vascular, musculoskeletal, and other areas. There is no end to where intervention can lead to. And in primary differences in this intervention in some of the Western countries is that intervention is predominantly performed by a radiologist who is better equipped because of his knowledge of the anatomy and the disease process. And in some situations, his other colleagues like vascular surgery and in some cases cardiology work very closely together to be able to provide a service which is unbeatable by any stretch of the imagination. So we will try and look at some specific case examples going through some of these specialties. And this lecture is really broadly based for a general population where I want that people to understand where we're coming from, so that ideas may come forth with regards to collaboration and research. So we'll start off with neurovascular advances that we have been doing. And a quote from Wilder Penfield saying that the brain is an organ of destiny. It holds within its a humming mechanism, secrets that will determine the future of our human race. And it is true, and the way that intervention has helped in neurointerventional radiology is one of the cases that you all commonly do at your institutes is for carotid stents, where you have a very diseased artery like this. This is a post-radiation stenosis that you can see. And are you able to see my videos okay on your screens?
Yeah, perfectly.
Fantastic. Okay. As you can see, the stenosis there. In order to do an open surgery on this one, you would be risking the patient with, possible major stroke events, etc. But intervention through, with the help of, guide wires and catheters, are able to protect the brain as well as treat these diseases. So treating them with a strategically placed stent across the across the carotid circulation provides new lease of life for this patient who, in other words, would find it very, very difficult, or it would have been a very risky procedure following post-radiation. So these are one of the advances that clearly have helped us move neuro intervention forward. And all of this is done through this very, very small hole in the groin, which is, if you think about it, those of us who are doing intervention, we don't necessarily take this into account, but when you speak to other specialties and other people, they're quite amazed that we are able to achieve this level of treatment using a 3 or 4 or 5 or 6 millimeter hole within the blood vessels, and leaving patients to be able to react very quickly. The other biggest advance is in stroke intervention, and this has taken the entire world by storm, where we are able to not only recognize the onset of early stroke, but if it is a suitable candidate, to be able to do this intervention very quickly, to be able to pass these special devices through the blood vessels called stent retrievers, to be able to take the clot out of somebody's brain. Now, I know that EU in Moldova have done a number of these cases, and I know some of your operators as well who have done these cases. And it is exceedingly one of the most innovative, one of the most simplest techniques that make a huge difference to the patient outcome. In our practice, our own colleague had the benefit of this device when he suddenly underwent a carotid artery dissection, and we rushed him in. He was an interventional, very senior interventional radiologist. We rushed him into the OR, and then we performed this procedure, and we were able to retrieve a good amount of clot from his circulation, leaving him completely independent now at the moment with a little neurological deficit. And we have noted, we have seen this in our own practice of how this makes a huge difference. And there is a lot of research going on how we should be able to deliver this groundbreaking service, not only just in the Western world, not only, but also in the across the world, in different continents, in Asia, in Europe, etc. How can we do this so that every patient gets the benefit of it and nobody is left with a deficit that they really don't need to have? So I think stroke intervention the interventional radiology or neurointervention has made a huge difference in these procedures here, as you can see on this graphical video that we look at. Moving on, we're going to look quickly at the cardiothoracic implications of intervention and how this technology and innovation have moved forward. For example, it affects biopsies, it affects tumor locations, lung ablations, brain insertions, thoracic vascular grafts, fixed elephant trunk grafts, cardiac intervention, cardiac valve interventions in terms of TAVI and trauma interventions, etc. All of these are different things that can be clubbed together just within the cardiothoracic intervention as well. So all of you may know what a TEVAR or thoracic endovascular aortic repair is. It is usually a complex procedure. If it is complicated, it has a high mortality, sometimes up to 26% in our patients. The post-operative issues, because the people that we're dealing with are generally elderly, they have a lot of comorbidities, they have stroke complications, and they're at risk of paraplegia. But can you imagine when Dake in 1994 described this classification in the thoracic aorta, come 20 years on, that we would be able to treat these complex aortic aneurysms right from the aortic valve all the way up to the bifurcations by using different techniques, different ideas, and moving these forward by also reducing the paraplegia risk to bring it down to less than 1%. It is a truly remarkable area where we are able to put these stent grafts through these aortas, no matter what the disease is, and be able to save these. Sometimes we do these cases either under the spinal anesthesia or sometimes even under local anesthesia when it comes to trauma, which for us is a big issue in Manchester or in around Manchester. We are the tertiary center. We get a lot of major road traffic accidents where young people generally tend to be hit, and this is one of the accidents where Princess Diana, who died in a car crash in Paris, actually died from this accident where she tore her aorta, and unfortunately this technology was not actually available during that time for it to be fixed. So this is a case that was very similar to that. It was a car chase case, and where you can see on the left-hand side that there was a trauma to the aorta with a dissection flap, etc., and there was a hematoma around the descending thoracic aorta. This was done with the patient awake, and he was talking to us whilst we were doing this, and we put this stent graft in, and the patient was discharged a week later with this. So it can make a huge difference. No complications, no spinal ischemia, 7 days discharge under local anesthesia. Patient was talking to us whilst we were doing this. Again, this has come out of innovation between different universities, different collaborations, and that is what we want to try and achieve with Moldova. This is another complicated case where this is a zone 0 thoracic aortic deployment, where it was too complicated for us to redo this procedure. This patient already had a kidney which was reconstructed but developed descending thoracic aorta, and we were able to use again the technology that was available to us to be able to deploy this very, very proximal stent across this aneurysm, maintaining cerebral perfusion at all times, but also maintaining or limiting the risk of spinal ischemia and complications. Again, this was done under anesthesia, and we deployed this stent after controlled heart rate that we generally tend to use in our thing. So one of the other areas which intervention has made a huge difference is in dealing with a pulmonary arterial venous malformations. In the olden days, we used to do multiple surgeries for these, and it used to be a very, very difficult thing to treat. We have a steady population of people, and can you imagine that one day that we will be able to cross the heart, go into the lung circulation, be able to deal with the multiple pulmonary AV malformations, preserving the patient's lung function, and be able to treat this. This again is a very good example of a recent case which I performed, where we were able to seal off these aneurysms, the two aneurysms, again, whilst the patient under local anesthesia and under conscious sedation, going through the heart, etc. Similarly, our cardiology colleagues do wonderful things, not only just PCI stents, but also be able to cross over from the right to the left heart and do a lot of electrophysiology studies and ablations, and very complex procedures as well. All coming together because of the innovation and of intervention that we are all seeing. So let's move on to our next specialty, which is vascular. How are we impacting in vascular areas? We are doing a lot of these endovascular repairs, and we call them pre-EVARs, or percutaneous EVARs, where the entire case is done percutaneously. So again, yesterday we had 2 cases. I was up in the operating theatre. Both patients were talking to us under spinal anesthesia, very similar cases to these, where we again make these small incisions like this here from your groin, and be able to reconstruct the patient's aorta in situ and to be able to do this. Now, I'm sure you are doing this in the vascular repairs in Moldova, and I'm sure you have attempted a lot of percutaneous endovascular repairs, but predominantly we are seeing that we are able to discharge these patients within 24 to 48 hours. And especially in a time like this when you don't want patients to be in COVID, in the hospital, this is very, very useful for us because they don't have any incisions to deal with. And this is far from doing an open procedure. So again, reduced mortality and morbidity, short stay within the hospital, which is very important for us during COVID times, and ambulatory advantage that patients can walk about very quickly and minimal complications and happy patients. This is a P-bar, which is a fenestrated endovascular repair. So as part of the complex vascular team here, 2 interventional radiologists and 2 vascular surgeons are involved in this team where we create these fenestrated components in the aorta, and we are able to reconstruct the entire aorta. Now, if I was to tell this to Dave or Beatty or any of our famous vascular surgeons in the past and say that we're able to do this, they would laugh at me and say, there's absolutely no way that we'll be able to do this. But now we're able to do this and bring the timings down to almost an hour and a half. This is an hour and a half procedure for us, and we are now doing it entirely percutaneously. So no cuts, just percutaneous access through the groins, and we were able to reconstruct the thoracic aorta from the diaphragm all the way up into the internal iliacs through various balloons, catheters, etc. Again, this is not possible if we did not have the collaboration, if we did not reach out to other centers, if we did not, if we are not able to go out and teach what we know and to learn from you what you can teach us as well. So that is where I want to be very clear how important this collaboration is. And can you imagine doing all these things through starting off with a 6 French to go up to a 24 French sheath, etc. So again, complex aortic injuries that we see here, for example, in this patient here, which had a biopsy in a local hospital, and I'm sorry the media doesn't play on this one, but you can see this aneurysm, which is right at the bifurcation of the renal arteries and the superior mesenteric artery. Very difficult to treat, and the complicated patient was not fit for open surgery, and this was very easily treated with Chemoembolization, which we could treat by saving all the vessels in situ. Again, I'm not showing you any cases that you may or may not have come across, but I am again trying to point out how swift interventional radiology treatment can save many patients' lives. This is another case which I did very recently. We call it a percutaneous ioto-bifemoral graft from the radial artery. And if you can imagine doing this from the radial artery coming in, the patient from the aorta has hardly any blood vessels at all to even recanalize, and we came in from the radial artery and we were able to recanalize and we were able to reconstruct the patient's aorta and iliacs through the radial artery and be able to stent and to be able to treat this. And the patient went home within 24 hours. This is a percutaneous ioto-bifemoral graft, and it is a new technique that we are developing at Manchester. And we will be very happy to share those. And this is the radial approach that we use. And for example, complex below knee procedures here, as you can see, very complicated. This is the knee joint, this is the popliteal artery. There is no flow, or the trifurcation is completely gone. This is a case that me and Frank did, and Frank wanted to do some surgery within the foot, and he said, could I improve some of the blood supply? And we did it both from the top and the bottom, and we were able to reconstruct with multiple wires, etc. And we were able to reconstruct the trifurcation anatomy, and the patient went on to have a partial amputation and wound debridement and kept his foot. Acute hemorrhage control, this is another case which had a partial nephrectomy. And if we did not have interventional radiology or intervention for that matter, or somebody doing intervention, this patient would have lost the kidney. You can see that there is an aneurysm within the kidney. It's a partial nephrectomy. Surgeons didn't really want to go in. If they go back in and try to repair, there is a patient who is very likely end up losing that kidney, and the patient only had one kidney. And so it is a life-saving, life-changing repair that we were able to do very quickly. This is a ruptured vessel. Again, patient was transferred from a different hospital. As you can see, the iliac artery is completely amputated with no possible connection. And again, the patient had a large abscess there, which was creating a lot of problems, a lot of bleeding. And we were able to immediately stabilize these patients, cross it, find the vessel, and be able to cross it, and be able to use grafts and stem graft, again through that very small hole, to be able to save this patient's leg and life at the same time together. And chronic limb ischemia, as I just mentioned, I'll quickly go to these. This is the same case that you can see another endovascular therapy where we're going in from the foot, from the distal side, and to be able to reconstruct these blood vessels in a way to allow the blood flow and inflow back into a diabetic foot, which comes very closely to what Professor Bowling is working on. And we both work very closely together to try and improve these blood flow to these foot, so that we can do a tissue-sparing surgery. And it affects even hepatobiliary, for example. What examples can we look at how intervention helps in hepatobiliary? Unfortunately, I did not have the opportunity to meet any of the hepatobiliary surgeons in Moldova last time I came. But again, PTC, stent insertions, chemoembolization, radiofrequency ablation, all of these are advancing therapies, not only vascular therapies, but also in the field of cancer. For example, this is a case of ablation where a patient has a 3 centimeter SCC in the liver, and we are able to treat this again easily within the CT scanner here with ablation. You can see me and my staff in the scanner. Patient that is awake, and we're able to put these probes within the liver and to be able to burn that tumor away. So this was before, this was the tumor, and this is after, and the patient had an unremarkable effect. And we're able to use more new technology, like for example this contrast enhanced scan, to be able to determine, ultrasound scan, to determine right there at that point whether we are able to cure the entire tumor or not, or whether we need to do more of these. So I think it is contrast ultrasound, again, a very innovative new technology. And I have a large research unit that I work very closely with in Canada, where I spent many years in the university, and we do 3D concept intervention, which I'm keen to collaborate with different universities, where we map the tumor and we know exactly how big, how much the tumor is, and how much energy we need to deliver into the tumor to be able to kill the entire tumor. Again, everything percutaneously without putting an incision on the patient. Transarterial chemoembolization, you know, this 3D rendering shows the capture within the hepatic artery, and where it shows the multiple areas of the tumor, and we're able to travel all the way into this fine little vessel. And if you can see on your screens, this is where we delivered the chemotherapy. Now this is a thing that really amazes many people and many patients who come in and say, why am I not having this therapy for all the different cancers? That why can't you do it elsewhere? But because of the wonderful blood supply of the liver, we're able to do these chemoembolizations both in the liver and the kidney, and sometimes in the spleen, to be able to reduce the tumors and decrease the tumors, and preventing the patient from going into a complete liver failure. And this is a really true super subspecialized therapy that can be given. And this is another example where not just chemotherapy, but I'm able to actually deliver radiotherapy into the patient's liver. And this is a patient that I did. And I delivered a yttrium beads into the liver to treat. So instead of having radiation coming in from outside, you have the radiation coming in from the inside to take away and kill the tumors. Again, it's highly innovative technologies which have been, which we've all established, and we've been training in these procedures, which can be of great benefit when we are dealing with such complex, liver lesions where it is very diseased, and these patients are really not fit for any open surgery, etc. So this is another case where we do something called the portal vein embolization. And this is one of the most amazing technologies that I think is worth a mention, where in a live patient, we are able to go into the liver and trick the liver into thinking that part of it is dying, and the other part of the liver, or the left lobe of the liver, then starts overcompensating and overdevelops, and thereby increases in size. So then we can go in surgery, and then we can remove that. So this one, the picture on the left-hand side, you can see that I have my catheter placed into the portal circulation, and then we embolize this with Iotrophy inside and special techniques, etc. This is what it looks like afterwards. And lo and behold, you can see the operative pictures here, surgery. 6 weeks later, you can literally see where you see my mount point. This is the right lobe of the liver here. And this, all of this with the surgeon's hand and my hand pulling the liver out, an entire brand new left side of the liver. And this patient went on to have a fantastic resection of the entire liver and the tumor, and he had a full, complete cure. Again, portal vein embolizations. Again, all of these are amazing technology. So gastroenterology, for example, the other specialty, as you can see, GI hemorrhages, dealing with them. We don't operate on GI hemorrhages anymore, and we do embolizations on these cases. Very quickly, I know I'm short of time. We're looking at the peripheral vascular cases again, where we're started to embolize these bony metastases with not only bland embolization, but chemotherapeutic embolizations to reduce the pain, and so that these can be treated from the orthopedic point of view, and these can be drilled out, or bone cement can be placed in, or can be resected, and the nailing can be performed. And furthermore, more of technologies like prostate artery embolization. This is a gift to all men who are watching this presentation, who are in their late 40s and going on into their 50s. The dreaded complication of having a TURP is now a thing of the past. You can do a prostate artery embolization, and I've done one case in the morning. I've got another case now where we can go into these complicated areas and be able to treat this prostate artery just like we treat fibroid embolization. There's a huge amount of research opportunities available in these, where we are able to decrease the size of the prostate and the patients become symptom-free. Again, we do all of this through the radial artery here. We don't use the femoral arteries anymore. And again, huge opportunities of learning. So I hope that during that presentation, I have demonstrated just a small pinch of what innovation and intervention can do moving forward, not only in our lives, but in your lives. And this is a specialty worth its weight in gold. We want to collaborate very closely with Moldova. You are very talented people, and you work very hard, and we really want the patients in Moldova to have the same benefits as everybody else who is going through this. And it is a teamwork, and we, as Professor Bowling has indicated, it is something that we want to work in collaboration. With that, from Manchester, thank you very much.
Thank you. Thank you for a wonderful presentation and sharing your experience. And I think we
I would just like to close the presentation. I'd like to thank Dr. Kani for a very nice technical presentation as part of the Congress. What I would like to emphasize again is certainly with the university and the University of Manchester, Nicolae Testemițanu University, we will start over the next, once we pass this COVID rate, we would like to start offering fellowship between the two. And that communication will literally be how we select students, residents, trainee doctors to come to the UK, to come to Manchester and undergo any training that they may need or they may like to undertake. That will also be in conjunction with joint PhD students. Both Professor Groper and I can offer this between the University of Manchester and Nicolae Testemițanu University, where we can start to offer joint PhD scholarships and joint fellowships between our two respective universities. I would just like to close by saying it's all about collaboration. Everything must be working towards working together. Working in isolation, unfortunately, in the 21st century, doesn't allow for grant applications. Grant applications must be between respected European universities, such as Nicolae Testemițanu, such as the University of Manchester, and other universities that I also reside within Austria. So I'd like to close the presentation. I would like to thank you all for attending. It's a huge honour and it's an even bigger privilege to speak at your 75th Jubilee. I would like to finish by, as I started, thanking Professor Groper for his intuitive nature in the way he wants to move forward with collaboration and the way he wants to move forward with research. It really is, you're very lucky in the aspect that you are Professor Groper and he wants to move research forward within Moldova. Mulțumesc. Do you have any questions? About Dr. Kikanian?
Yes, there are some questions from my colleagues.
Porniți microfonul.
Okay.
Okay. Did you hear me?
Nu, n-are ce microfon. Spune-te dacă te-am plătit astăzi.
Dar у нас прокуратура să ne vorbim așa la microfonul să faci, nu?
Nu, eu altfel aud eu. E ca cum am
Okay. Can you hear me? Dr. Kakani, can you hear me?
Da, el ceva vorbește.
Mai suntem în fără.
Acum? Ia, da.
Okay. Can you hear me?
El vă uite, dar nu anunță.
Okay, so I hope you can hear me. I want to thank Dr. Kakani for this fantastic presentation. And of course, there are no doubts what interventional radiology changed dramatically all fields of medicine and especially the surgical disciplines. And we use it frequently, but in many clinical situations, the open surgery still have a role. Yeah, for example, an unfavorable anatomy in case of some very extensive lesions, in case of graft infection and so on. In your opinion, the interventional radiology should develop like an independent specialty in the future, or we should incorporate these endovascular skills in another specialties like vascular surgery, orthopedic surgery, urology, general surgery, and so on? What will be more correct in your opinion?
Eu să opri. Totuși o să înceapă. Ok, ei au ieșit din întâlnire, nu știu că să mă reconectează.
Bine, dar atunci puteam să comentăm pentru colegii noștri care mi se uită.
Da, dacă până se conectează domnul profesor, eu chiar aș vrea ca noi să purtăm o discuție, pentru că consider eu că este o temă foarte interesantă la etapa actuală, chiar și pentru Republica Moldova, în care sunt intenții de a dezvolta această ramură a radiologiei intervenționale. De ce, domnul profesor Cotneanu, eu vreau să vă întreb dumneavoastră, pentru că s-a vorbit despre componenta radiologiei intervențională gastroenterologică, cum o vedeți dumneavoastră implementarea ei, în ce măsură și cine ar trebui să o efectueze?
Știți, domn prorector, e cam așa, un pic a vorbit timid despre ceea ce facem noi în Republica Moldova, adică ceea ce face dumnealui Republica Moldova. Într-adevăr, în Republica Moldova se face foarte multe lucruri. De fapt, dacă vorbim despre chirurgia ficarului, ceea ce a menționat chirurgia hepatobiliopacratică, ceea ce a menționat domnul Cacani, noi suntem în dezvoltare. Noi, practic, toate metodele acestea care le-am menționat, bine, în afară de unele metode care sunt legate de costuri, ca tare, adică transarterial radioembolization, adică sunt legate de costuri, noi nu le avem. Dar nu le avem, nu de atâta că doctorii intervenționiști poate să le facă, dar deoarece contrastul nu poate. Hello?
Yeah.
You can hear?
Yes, we can hear you.
Oh, super. We have super. So do we have questions? Any questions?
One more time.
Puteți să vedeți tot și aici. Okay. Just a second. We have several questions.
No. Good.
Hello, can you hear me?
Hi.
Yeah, I
Yes.
have a question to Dr. Cacani and to you. Of course, the interventional radiology changed dramatically our activity in different fields of medicine and surgery and urology and other specialties. In your opinion, what is the future of this? It should remain the independent specialty, or we should incorporate the interventional and the vascular skills in another disciplines, in orthopedic surgery, in vascular surgery, in urology, cardiothoracic surgery, and so on. Or it should be just independent group of specialists in interventional radiology. This is my question.
Okay, so I will just, as somebody on the side, sitting on the side from it, and Dr. Tocada will intervene in 1 second. And what we see here in Manchester and the outcomes that we see, the clinical outcomes that we see are absolutely excellent. And it should be via a interventional radiologist as a specific discipline in its own right. These are people that are doing this on a day-to-day basis, who are trained within complex anatomy, and the outcomes that we see stand for themselves. Please.
Yeah, I agree with Frank, and I have worked in areas where intervention has been performed by a number of other specialties. For example, I worked in North America for a very long time, as well as working in the UK and Europe. And what I find is that the group of people that need to be doing this are the people that are doing this every day and night to get the results that we want, so that these results can make the innovation go forward. It doesn't necessarily mean that other specialties may not need to collaborate, but in Manchester we seem to work very, very well when we collaborate together, when we work together and move forward, whether it's complex vascular or whether it's complex HPV. I will give you an example. We do a lot of fenestrated cases here, and these fenestrated cases are always done by 2 vascular surgeons and 2 interventionalists, and the results are exceeding because we are able to take each other's skill sets and do even bigger things. That is the most important thing, that collaboration, I think, is the key. And if you do not collaborate and you isolate yourself into one area, that is where things will go wrong.
Thank you. So, if I understand, the key of success is interdisciplinary approach in these cases. Okay, and my second question, very short. With increasing number of endovascular procedures, the surgeon performs less and less open procedures. This is a problem in training. How it can be overcome, and what we should do to maintain the required level of skills, of open skills?
So yeah, I completely agree. Obviously, you cannot lose the open skills, because if you hit a complication, you need to open the patient. As surgeons, we know this. We know Dr. Kulkarni, Nirmal know this also. And this is why we work in collaboration. So if a problem does occur, then we can open the patient together. And that's this cross-fertilization between these 2 very specific, specialized disciplines work very, very well. But I am in complete agreement that I can say for the years that I've worked with Nirmal, very rarely we do see a complication. We see complications, but they're very minimal. But when a complication does occur, as anywhere else, we work as a team.
And I think a more specific thing to what you're saying is with regards to training. I think the way that we have addressed the lack of skill or the so-called fear of de-skilling the surgeons from their operating is that we encourage them to scrub in for all our open cases as well as endovascular cases, so that they get an idea. And their training, I think, is a paradigm shift. I think we have to move away from the time where we're just thinking about just surgery and as intervention as 2 kind of varied specialties which are going away from each other, but we have to think of it as these 2 specialties which are actually coming together to form into an endovascular, endosurgical, endoradiology kind of a specialty moving forward. I think that is very important, and that's what we have learned with our trainees, that we encourage them to do both intervention and open as much as they can. And for all you know, it may be that 20 or 30 years down the line, a particular procedure that we are doing may be completely obsolete. You as a vascular surgeon would know that. There are surgeons, there are surgeries that we just don't do those anymore because we think that the mortality and morbidity of those are too great. So they will be relegated to historical, but we, people like yourself and me, etc., who are already in those areas, it is our responsibility to make sure that our trainees train together so that this new specialty, whatever it may have, whatever it may look like, will be born.
Thank you very much. Thank you. Thank you. Nice presentation. Thank you.
Thank you.
One more questions.
Hello, Professor. Thank you very much for a great presentation. Thank you very much, Dr. Kakani, for this presentation. I just want to ask you about, in this difficult period of time, with pandemic situation, with COVID-19, your activity is less activity. Do you have less activity or more activity, or some special intervention on this patient with COVID? Because they have complications, thrombosis, and maybe your implication is more in this period of time.
So we do know that obviously if a patient is intubated, ventilated under general anaesthesia and they are COVID, i.e. they're COVID positive, their mortality rate is about 40%. That is what the data shows at the moment. So if you have to take a patient to theatre for a general anaesthetic, where the patient is intubated and ventilated and they are COVID positive, on top of the mortality rate that they already have for the procedure, the mortality rate is 40%. That's a paper published in the New England Journal of Medicine some 6 weeks ago. That is what it's showing at the moment. With regard to activity levels, then Nirmal can answer that question whether they have reduced or increased over this COVID period.
Yeah. I think we have noticed that the activity has actually increased during COVID. It is not decreased. We were also under the impression that with all the reduction in the cases or the elective cases, our activity came down. But we found ourselves doing a lot of embolectomies, a lot of issues with thrombosis in patients, a lot more sicker patients. So all of these has increased tremendously. But we also note that is initially. So in the March when we hit our peak, etc., there was about a week or 2 weeks where we had a little bit of a slowdown. Only a little bit of a slowdown. We were seeing a lot less number of accidents on the roads because nobody was allowed to go out. And we were seeing a less number of patients in the hospital because nobody wanted to come into the hospital. But after that, it has really shot up and is increasing. Then now what we're facing is all this backlog of patients have become more sicker. So the aneurysms have become bigger, the legs have become more sicker patients, and they're coming with more and more comorbidities. So we're dealing with that. So overall, I think the activity has increased and slight variation in things that we're doing for COVID patients, but not a huge difference, in the sense that I don't think that there is a new technique or new procedure that we're doing specifically for COVID patients.
Well, I've just finished that question that you asked. It's a very nice question that you asked. And what I can say, I'm the Professor of Surgery here at the University of Manchester, and I've operated more in the last 6 months than I've operated in the last 5 years. A lot of the time I spend in my office, and for the last 6 months I've been operating 80 hours a week. We've been in clinical contact 80 hours a week during this COVID period. It's been crazy. It's been crazy. But what I would say is a very important message is any patient that you take to the OR who needs to go under general anesthesia, who is intubated and ventilated, and they are COVID positive, have a 40% mortality because they are COVID positive. And then you've also got the mortality of the actual procedure. I think it's, so when you're taking these patients to the OR, you have to be absolutely sure that they need to be in the OR. Does that make sense?
Yes, indication.
Thank you.
Thank you.
Thank you very much.
Nice question, thank you.
Actually, I want to thank you to your great presentation. I'm a HBP and liver transplantation surgeon, and it's very interesting that you do and that you did in your center or in your hospitals. And we are here to collaborate, and we want very much to collaborate.
Yes, thank you.
And Dr. Kakani, and we are in the future, if it's possible, we can collaborate in this domain. You know, the Republic of Moldova, it's an endemic zone of hepatitis, and we have a lot of cases of hepatocarcinoma on cirrhotic patients. And this is very interesting. We start collaboration of...
Okay.
Yeah, and okay, thank you for your great presentation.
Thank you. Thank you very much for the very very nice comment. What I would say to answer that very, very briefly is both Professor Grover and I, over the next 12 to 18 months, will be setting up fellowships where people from, or doctors from Moldova can come to Manchester for any further training or any clinical training or academic training that they may need or may wish.
Professor Bowling, Dr. Kakani, thank you for your presentation. So we hope that in future we'll not leave a personalized medicine and go to the generalized one that it was sometimes, because we fight a lot for that. And on behalf of our university and Professor Gropa, we thank you for your presence today and thank you for the great talk and sharing your experience. And we'll have a gift for you, and I think by DHL it will come in several days.
Thank you.
And for your presence. So thank you for a wonderful talk.
What we would like to say, both Nirmal and I, what we would like to say is the people, the participants, the doctors who are sitting in the audience are the most important people. They're the ones that the reason why we do all this research, we do these presentations, is for knowledge for the greater good of the patient. So we would also like to thank you and your university for setting up this splendid conference.
Yes, thank you very much.
Thank you. Thank you.
Noi pe final am vrea să transmitem fiecare din moderatori câte un mesaj. Domnul profesor Pătneanu, vă rog frumos dumneavoastră.
Alex, we're signing off now.
Yes, we have just a final message for our colleagues in Romanian. So thank you for your presence.
Thank you.
Thank you.
Cu toate noi mulțumim colegilor din Marea Britanie pentru aceste prezentări. A fost o prezentare, într-adevăr, care a mers de sus până jos. Adică au fost toate practic, profesiile medicale prezente aici și este un domeniu foarte important care sigur că la noi se dezvoltă foarte bine. Asta e părerea mea. Noi colaborăm ca chirurgi de chirurgia ficatlă, că aici s-a pomenit chirurgia ficatlă și a pancreasului, noi colaborăm cu medicii radiologi, că cei sunt intervenționiști radiologi și este un domeniu foarte important, căci fără aceste tehnologii care le-a pomenit domnii doctori, nu este posibil chirurgia acum, în ziua de azi vorbesc de chirurgia mea. Și cred că este un domeniu foarte de perspectivă, care și Universitatea de Medicină cred că contează pe el și în formarea specialiștilor și în educația acestor specialiști.
Da. Vă mulțumesc mult, domn profesor. Domn conferențiar Căcean, vă rog frumos și dumneavoastră să vă expuneți părerea despre acest topic.
Da, mersi. Desigur că este o prelegere foarte interesantă și foarte importantă și mesajul, sunt absolut de acord cu mesajul de bază care a fost în această prelegere, că cheia succesului este colaborarea între diferite discipline. Radiologie intervențională, așa cum consideră prezentatorii acestei lecții și cum probabil că este corect, trebuie să dezvolte ca o specialitate aparte, deoarece numai persoanele care sunt implicați zilnic într-un număr mare de aceste intervenții pot obține rezultate bune, da, având experiența vastă, dar în același timp, în fiecare caz, noi trebuie să alegem pentru fiecare pacient în cauză o tehnică cea mai bună, tehnica oportună și nu neapărat aceasta să fie endovasculară sau deschisă, adică fiecare pacient necesită un abord multidisciplinar și tactica de tratament trebuie să fie discutată între cei care posedă și intervenții endovasculare și cele deschise. Felicit pe toți cu sărbătoarea de astăzi și cu deschiderea acestui congres aniversar. Mersi.
Eu vreau să zic că rămân convins că comunicarea aduce răspuns la foarte multe întrebări și vreau să mulțumesc acestei platforme care a fost formată pe baza Congresului aniversar 75 de ani de la formarea Universității de Stat de Medicină și Farmacie Nicolae Testemițanu, că ne-a dat posibilitatea să discutăm cu specialiști de peste hotare și însă și noi, specialiști din diferite domenii de Republica Moldova, să comunicăm în a decide că ce este mai bine. Dar mai bine este totuși abordarea multidisciplinară, în așa fel ca de anume beneficii până la final să-l aibă pacientul nostru. Eu sper că așa tip de comunicări noi vom avea și pe interior, pentru că fiecare din dumneavoastră cred că are de ce spune și o experiență vastă în acest domeniu. Vreau să mulțumesc tuturor și să vă doresc succes în desfășurarea etapelor următoare ale Congresului.
Mulțumim!